Yes, I see Dr. Majid has. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Uh, it's 9 o'clock here in Riyadh, so it's time to start our second day and for this conference for session 5. So we welcome you in Riyadh or in any of the Saudi cities or wherever you are joining us. And inshallah, if we have a wonderful day like we had in the first day. The session 5 is titled Blockchain, and it will be chaired by myself, Dr. Raji Sadhan from the College of Dentistry, King Saud University, Department of Oral Medicine and Diagnostic Sciences. Please also join me welcoming our co-host, Dr. Mona Al-Shardan. Our session will have 2 speakers. There will be a breakout session after the presentations that will be joined only by Dr. Abir Al-Hnaimidi, the second speaker. Dr. Majid Al-Mansouri, our first speaker, he will not join the breakout room. So if we have time to address some of your questions, please type them in the Q&A section of this application. We will try to accommodate as much as we can if we have time. It gives me a great pleasure to introduce our first speaker, Dr. Majid Al-Mansouri. Dr. Majid is a physician scientist and an assistant professor in the clinical chemistry department, Faculty of Medicine, King Abdulaziz University in Jeddah. With nearly 2 decades of experience spanning academia, healthcare management, emerging technologies, entrepreneurship, and innovation, Dr. Majid brings unique multidisciplinary perspective to every challenge. Dr. Majid is passionate about creating and scaling solutions that leverage digital transformation and emerging technologies, in particular blockchain technologies. Dr. Majid career encompasses strategic consultancy and business development across both private and organizational and governmental entities, focusing on supporting Saudi Arabia's Vision 2030, achieving its key initiative. Dr. Majid helps to shape transformative national programs throughout technologies-driven approaches and innovative framework. And in this line, he will gonna present for us the topic of digital health revolution, transforming Saudi healthcare through blockchain, IoT, and VR, a vision for 2030 perspective. Dr. Majid, تفضل.
Allah يزيد فضلك. السلام عليكم ورحمة الله وبركاته. Good morning, everyone. Prof. Sadhan, Prof. Asma, Prof. Fatma, Prof. Mona, and all the esteemed speakers, as well as Dr. Abdullah, and all the different staff from King Saud University for this annual hospitality. And it is with great pleasure to be here, and it is with great pleasure to not only be a speaker here, but to be a part of this ongoing conference year on year. And it brings me with great pleasure, really, to be the opening speaker for this day. Today, we're going to have a lovely day, inshallah, about multiple topics about emerging technologies and their intersection within the healthcare system, locally in Saudi Arabia as well as internationally. And for this specific occasion, I decided to really go with more of a general approach on the emerging technologies that are really positioned to revolutionize the digital healthcare ecosystem in Saudi Arabia. And I hope you enjoy this session. Thank you very much. Without further ado, let's get going. So first of all, if we really dissect the digital health ecosystem, we will see that the 4 main pillars of the digital health ecosystem are the 4 main emerging technologies you can see in front of you here, which are mainly, of course, AI being the one that is mostly used, or the one with, let's say, high potential, or the most potential of really revolutionizing the digital healthcare ecosystem, followed by Internet of Things, blockchain, and virtual reality. Let's take them one by one and dissect them and see how they really help revolutionize the healthcare ecosystem. When it comes to AI, we're mainly talking about machine learning algorithms enhancing the diagnostic accuracy, helping in the predictive analysis for the physicians and for the clinicians, as well as delivering personalized medicine. And we're going to stop with each of these technologies and talk more about them. When we talk about Internet of Things, and if you look at the literature in the past, let's say 10 to 15 years of Internet of Things and the innovation that has been taking place in healthcare, you will see that it mainly encompasses the connected devices, the digital wearables, the stroke detectors, and all those different devices that really deliver the smart healthcare environment, as well as the home healthcare and the home diagnostic tools. When it comes to virtual reality, this is maybe of great interest for us in particular, that most of us are here in the academic environments and in academic backgrounds. Virtual reality is really very well positioned to be the leading technology when it comes to medical schools and medical and clinical education. The immersive environments that virtual reality really provides revolutionizes medical training, patient care, patient simulation, as well as therapeutic interventions, and really minimizes the error that might come out of the using the traditional training methods, let's say. Finally, blockchain. Now, whoever knows me knows that blockchain is the technology I'm most passionate about. I've spent nearly a decade working on it. So I'm trying not to be, I don't want to look biased when I talk about blockchain in front of all these, compared to all these technologies. But when it comes to blockchain, really the key in blockchain is the distributed ledger infrastructure that it provides, where it really highlights a very well-positioned solution to a gap that has been in almost every healthcare ecosystem, not only locally, but internationally, which is the data and the patient data and the immutability and transparency of the data. Whether it was because of ownership of the data or misuse of the data, or allowing to have a secure database that really saves that patient data and allows for selective exchange between insurance companies, all other third parties, and all other different stakeholders within the healthcare ecosystem. So to really summarize these four technologies, we can summarize it by the statement below. These four technologies are not isolated innovations. They work hand in hand, and they are interconnected forces to really deliver what we believe to be the revolutionized digital healthcare ecosystem for the future. Now, if we take each of these technologies very briefly and talk about them, and about the innovations that happened in them in the past, let's say, 2 decades or 15 years. Blockchain in healthcare really gives the trust and security. This goes all because of the technology fundamentals. The distributed ledger technology allows for data integrity. The cryptographic algorithm and the cryptographic nature of blockchain ecosystems really allows for the security, protecting data information from any tampering, and also showing any timestamp for any, let's say, alteration that took place to the data of that patient. Smart contracts really are very well positioned to automate the healthcare process and allow for the exchange between also the other healthcare providers. So they are a very potential technology to really revolutionize patient data management, pharmaceutical integrity, as well as research transparency. And I really want to stop at the third one. How many of us submitted a paper for publication and was asked to send raw data? Let's say raw data of qPCR, or raw data of patient information, or raw data of laboratory investigations for liver function tests, or so on and so forth. Instead of having that, there has been multiple proposals for creating that unified research database, where it pulls data from research machines with each verifier and each identifier number of each of these machines being located in King Saud University or King Abdulaziz, or so on and so forth, and collect that data in real time in an immutable database. And when we say immutable, we mean that a database that does not allow you to really edit on the data. It's not like an Excel file or a Google Sheet where you can go at any certain point in time on change numbers or alter numbers. Here you're talking about trusting the code, trusting the ecosystem. When we have a blockchain infrastructure, all scientists, all potential scientists and participants in research have trust in the code. So there is seamless trust between all different involved stakeholders. When it comes to Internet of Things, as I mentioned, it's mainly about the patient wearables, as well as the different key components that the IoT healthcare ecosystem really gives. When we talk about an IoT healthcare ecosystem, we're talking about an ecosystem where patients have wearables that are connected to the same networks as these hospitals. There is seamless monitoring for the patient, seamless storage of data on the cloud, as well as different clinical tools that help the clinician really assess the case, as well as ensure that he's having full monitoring of that patient, whether it was a fasting or a random blood sugar sample, blood pressure, heart rate, respiratory rate, and so on and so forth. Some of the transformative IoT applications in Saudi healthcare really give us things that would really revolutionize how we look and care about our patients, such as continuous monitoring, smart facilities connected with these devices and connected with real-time monitoring of the patient, as well as rural connectivity in some of the areas, in the rural areas where let's say super or advanced hospitals are not yet there, and they have to really cross distances to reach to the nearest, let's say, central hospital in one of the municipalities or one of the cities near them. When it comes to virtual reality, and I'm being conscious with time, when it comes to virtual reality, really, like I said, this is of great interest and special interest to us as academics, really. It's very well positioned to revolutionize medicine and medical education via having these different simulations. If you just go into YouTube and see the different examples, whether it was local or international, of simulation centers based on VR that really simulate the experience of doing an OR or doing a medical procedure, it will really revolutionize how medical students' journey would look like in the future. Many of the different technology capabilities are the high fidelity immersive environments, the mixed reality integration with real world objects, also the motion tracking, the precise interaction, the haptic feedback, as well as the spatial audio enhancing immersion, and all these different, let's say, technology capabilities that really create an experience for the student that was never, we have never dreamed of, let's say. Now, as for and away from the teaching and the education, when it comes to the clinical VR applications, we have the surgical planning and training, of course, as we mentioned. We have rehabilitation medicine based on VR systems. We have VR distraction pain management system. Yes. Was somebody asking something? Okay. We have VR distraction pain management system, and we also have the exposure therapy using VR to treat some of the cases of the mental health in mental health patients, such as PTSD, phobias, and many other different, very, very interesting use cases for virtual reality. Now, to really summarize, Vision 2030 and the mainstream adoption and digital health ecosystem, as you can see, the government has done amazing, extensive work, whether with MOH or different other stakeholders, such as us as universities and many other key stakeholders in the healthcare ecosystem, to really build this infrastructure development. And I say it with really full confidence, and I'm really proud to say it, but we have one of the best networks when it comes to 5G coverage in the world, potentially. And maybe we can all see that when we see a lot of our friends who come visiting, and our colleagues that really talk highly of the network and the digital infrastructure of Saudi Arabia, whether that was in passport services, in all different Ministry of Interior services, and so on and so forth. We're very well positioned to really be a leader in the mainstream adoption and digital healthcare ecosystem, and set an example for countries not only locally within the Middle East, but also internationally and across the world. The economic and social impact for having that digital healthcare ecosystem would really affect the rural healthcare system and do a rural healthcare transformation, regional medtech leadership, as well as public health improvements, and increasing the general health and well-being of all society. And I will end with this statement just on time. So together we can really build a healthcare ecosystem that is more accessible, more efficient, more personalized, and focusing on personalized medicine, as well as more effective, fulfilling the healthcare promises of Vision 2030 and establishing the kingdom as a beacon of medical innovation of the world. Thank you very much.
شكرا دكتور ماجد. We have time for if any of you attendees would like to interact with the speaker. We have a few minutes or questions and answers. I don't see posted any questions, but any of the attendees would like to type his question, we will post it to the speaker.
Assalamu alaikum, Prof. Raed.
تفضلي.
If there's no typed questions, may I ask a question?
Go ahead, yes.
Okay, Assalamu alaikum, Dr.
عليكم السلام ورحمة الله
وبركاته. Thank you very much for this very interesting opening.
الله يسلمك.
دكتور ماجد كنت أبغى أسأل بخصوص blockchain. Now, we are not computer scientists. We are from the medical field. So we always have this fear about safety, security of the information. And when I really was fascinated when you talked about its application as a central reservoir for guarding the integrity of research. But the first thing that came to mind is how about the protection of the research from outside sources? So, for example, if we were to have a reservoir of information, I don't know if that's what you call it in blockchain terminology, but if we had something like that for each university, for example, or it seems to me that it would be more useful on a countrywide level. Would that allow people to utilize information from, for example, my research, if they had not obtained approval from IRBs or so forth? So, for example, when you say that the journals, they want the raw data, would it be wise to allow the journals to access this centralized reservoir of information?
Yes, excellent question. So, because our minds are really focused on the classical way of sharing data, unless you use the smart contract or integrated with a smart contract or with a blockchain technology, you will not get the sense of how blockchain really transforms data sharing. Now, when it comes to blockchains, blockchains are different types. There are public blockchains, private blockchains, and then there are hybrid or consortium blockchains, which are a mix between both. And I believe the perfect blockchain infrastructure that is fit for that specific use case is a mixed one. A one where it has public access to make sure that this data used in the research is actually authentic. So for example, I can scan a QR code from a certain journal and access the raw data of the qPCR or ELISA data figure that is posted on the paper. This is one side of it. And then the private side, where is smart contract regulated or smart contract permissioned, that allows certain people, certain users in a certain time frame to access data, and they can that permission expires at a certain time. So it really provides that mixed permissioned use case that is really perfect for science, for data, and for scientific research. And I believe the next speaker, Dr. Abir Al-Hamamidi, mashallah, is an expert in that field. And mashallah, Prof. Asma, you always do a great job in terms of lining the speakers about the different relative topics. So I'm sure that with her expertise, she can add a lot on that topic. I also believe that she might touch on that in her talk as well.
ما بعدك يا دكتور.
الله يسلمك. الله يسلمك. عليكم السلام ورحمة الله. أبدا بالعكس. الله يسلمك. الله يسلمك يا بروف.
شكرا لك دكتور ماجد، استمتعنا بهذه المحاضرة.
وحاب أشكركم وأشكر جامعة الملك سعود وإدارة الكلية الحقيقة على هذه المبادرة الجميلة، ويعني شرف صراحة أنه أنا معكم year on year in this great initiative. Thank you so much, and I'll leave you to have a great day inshallah. Thank you so much.
السلام عليكم ورحمة الله وبركاته. شكرا دكتور ماجد for this great presentation and giving us this overall talk about technical subsystems, a technical overview of healthcare subsystems. شكرا دكتور رائد for co-chairing the session. أنا منى الشردان. I will be co-chair the session and introduce the next speaker. As Dr. Majid said, Dr. Abir is an expert in blockchain field, and it's my pleasure to introduce her. Dr. Abir is an assistant professor of software engineering at King Saud University, the founder of the Blockchain and Web3 Lab, and she's the COO of Advanced Aerotech. She holds a PhD from King's College London and an executive certificate from MIT Sloan School. Dr. Abir is an active member of the Human AI X scientific committee and global communities such as IEEE Blockchain and the Blockchain Council. She's also an award-winning leader recognized as Woman of the Year in AI and Blockchain 2024, mashallah, and a recipient of the Circle of Excellence Award 2025. Today, she will presenting her work on blockchain-based solution for verification of medical qualifications in Saudi Arabia. Just before we begin, a quick note for everyone attending. Please feel free to type your questions in the Q&A box during the presentation. If time allows, at the end, Dr. Abir will happy to address them. Additionally, Dr. Abir will be available in the breakout room scheduled after the following session for further interact. Dr. Abir, the floor is yours.
Thank you, Dr. Mona. Thank you for this introduction. Thank you, and I'm very happy to be with you in this interesting conference for the second year. Thank you, Professor Asma, for the invitation. Maybe because I'm technical more than medical, because Dr. Majid is a doctor coming to the blockchain and I'm a technical one. So if you feel a little bit the presentation a little bit coming to the technical, just please apologize me. Is it in the presenting mode, Dr. Mona?
Yes, it's clear.
Okay. Okay. So I will start. This is a project that we worked in while I was working in the government before. Then I bring it to the research with the students to provide it like to provide a realization of the idea. So what's the idea comes to me just to in this presentation, I will cover the introduction, introducing the problem and the solution. And after that, I will introduce a little bit the solution itself, the big idea, the architecture, the realization, suggestion. Then after that, I will go to not the evaluation, but what is the second phases from this project? What's the future of the project and the conclusion? So the project comes to me, the idea comes to me first when I was sat with my relatives who was a medical doctors and dentist who was talking about that they paying more than 1,000 riyal to a third company to have their license from the commission, the medical commission, the qualification commission, and they pay it for a third party to verify their qualification, and it took more than 1 month for verifying their qualifications. So I thought this idea, this problem can be solved by using a new technology like the blockchain, which can be solving the problem very easily. So in the healthcare, the blockchain has been used in different ways. And in the last year, I, for example, introduced how the blockchain used for a drug prescription tracking. And it was used heavily in the electronic medical record, and it also used by hospital rating, by sharing resources between different hospitals. However, the concentration for this One is how we use the blockchain in verifying the genuinity of medical professionals' qualifications, which is the main problem for this talk. So in Saudi Arabia, the Saudi Commission for Health Specialty is the authority responsible for validating, verifying, and equalizing medical qualifications. And I will not say it for you because I think most of you are medical professionals and you know that. So in the commission, the commission uses a service of international specialized private company like the Data Flow, and I took this name from my relatives to verify the medical qualifications, such as services for a private company, burden the budget of the commission itself, the professional as well, and the medical institution if they will pay for these fees if in the case of overseas professionals. So another companies, for example, can be instead of data flow, there is also ABIC and other companies who's trusted by the commissions and also globally as a verifier for the medical professional qualifications. I'm right? Is it the case as I heard from my relatives? I think yes. So let us start by giving the idea of the solution. So we said, okay, we will put between the verifier and the issuer a private blockchain. So it's not a public blockchain, and the difference between the public and the private. And the private, it has a governor, it has an owner, and the public, they don't really have a public an owner or a governor, and it's open for everyone to participate in that. So we propose it and we call this blockchain to be the MQ chain, in short of medical qualification. So the main idea, this blockchain will have the issuer, which can be universities, training centers, hospitals, anyone who can issue or trusted to be an issue a certificate. And there is the verifier. Anyone would like to verify if it's the commission or the other recruiter or anyone else outside the medical environment. And we have the wallet owner, which is it should be the professionals, and it can be also generalized for other certificates. The flow of it, that the issuer who has will issue the certificate will use a website to upload the certificate to the blockchain. So the blockchain will not take the whole certificate, will hold only the hash. And that's why it doesn't really need to be a huge center for all certificate. It's only the hashes. And after that, it will have also a website for professionals, which is called the professionals portal, where professionals can see these qualifications, can send it to a recruiter for verification. They can print it. They can do anything. It's like a repository for all their qualifications that comes from any issuer. And for if they would like a verifier to verify their qualification, they just send an email like example, or even a print if they would like print the digital print for the verifier in their own will use the website for verifying the qualification from the blockchain. Okay. So what's the architecture that we proposed? We proposed we implemented to be in a 3 layers. The presentation layer, which is the web app of a recruiter, the web app for certificate issuer, and the web app for the professionals. And the applications where we deal with the blockchains, and the data layer, which is the blockchain itself. And we successfully implemented, we successfully implement we successfully implemented, but before presenting to them presenting for you the implementation, let me discuss with you as well how we think about the project to be within the Saudi context. So we think to make it working, that knowing universities or centers within the Saudi Arabia, they can register in the application, and they send all or upload all the certificate that they issued as a bulk inside here, as a bulk inside the system. Or if it's outside our inboard university or inboard medical training center or something like that, that system will provide a link that can be given to this university. If they don't want like to join the network, they can only use this link to upload the certificate for the students, or it can be given to the student, but we didn't do that because we don't really want to we think, not the students, I mean the professionals, I think it will not be trusted by the verifier for the student to upload their own. It should be the issuer who uploaded to the system. So, or it can be, as I told you, individually and online input for a specific certificate. And we allow the governor to put it inside the blockchain that that's under its responsibility. And after that, the verifier, it can be also public as a commission if they would like to verify a list of verification in the same time, and or it can be individual if it's a recruiter or something like that, they would like to verify the verification of the medical professionals. And also we think about a mobile, as we said, a mega app. We thought that Tawakkalna and Sadaya may be one of the professional governor proposed governor for this one. So the medical professional can see their verification inside, for example, any mega app, the one with the from the commission or from Sadaya or Tawakkalna. That the most important that we have a specific interface for the student, for the professional, where the professional not only can see their verification and print them, they can also ask if there is a problem with their verification or something like that. They can communicate with the issuer directly. In the system, we have, as I said, that we propose it as for to be Sadaya, but it can be a governor, not any governor. So that they will manage the issuers and the verifier invitations to the system, and they can approve or disapprove people from institutions, I mean from joining the network. And we have the issuer. The issuer in their self, they can manage their students or the one or the trainees, and manage the degrees, and also issue credential for students if it's invited as a whole inside the system. So they can provide their, like for example, if it's a university, the university will be the one who responsible to give their students the credential that they can log into the system. The verifier, they can only verify any credential given to them. They don't have any governance inside the system. And for the professionals or the students, they can verify the credential and download the credential for the first time or communicate with the issuer in the same time. We successfully implement the system. So we have we implemented in the first time to be, as I told you, we have different suggestion. So in the first prototype, we think that the Wizarة التعليم, maybe the governor as well, one proposed system, proposed governor for the system. So they can see the organization who's in the system. They can see only the issuer. They can use and see the verifier. As you can see here, Jadara is a verifier for the registered in the system, or you can have different universities who register in the system as an issuer. And we have the issuer interface where they can upload the certificate. For the first prototype, we ask the issuer to upload it one by one, but this is not reasonable. So in the second phase or in the future, we think to allow an API between the system and between the university system, so it will be pool the information directly from the SIS of the system, so it can be introduced inside the system. But now we introduce it where they can issue certificates, credential, they can view the user, and they can view as well the degrees. For the verifier interface, when they received the credential, they can verify, and it will be they can upload the file that received it via email.
Sorry to interrupt, Dr. Abir. 2 minutes to end the lecture, please.
Okay, so they can upload the file that's received by email, and they can verify it. And this is the professional interface where they have their credential, their certificates. Second phase, to have it as a consortium. A blockchain with all the GCC universities, and after that all the Arab university, and if we have a global, that will be perfect. So I present this in this presentation, the MQ chain, our project. I present the design, the architecture, and the deployment. So one of the direction that we think that it can be to promote used is also used by the hospital to promote practitioners to potential recruiter by the hospitals. So this system can be used for different things, not only for verification, but as well to have it as a store for medical qualification. So the recruiter, for example, the hospital can propose some professionals for promotion for different things. Thank you very much. I think I comes to the end of my presentation. I hope in this short time I was able to present the idea and the presentation, and the realization of the idea. Thank you very much.
Thank you very much, Dr. Abir, for this insightful and engaging presentation. I really liked how this idea came from real discussions with people from the medical field. It's a great example of how important the collaboration between computer scientists and medical perspectives, which this symposium helps foster. Thank you very much, everyone. This concludes our session. Thank you to all speakers and attendees. And we encourage you to join us in the breakout session after the following session. Dr. Abir, inshallah, will be there, right?
Right.
Thank you very much. Thank you very much.
Thank you, Dr. Mona. Thank you, Dr. Abir, for this presentation, and Dr. Mona for co-chairing the previous session. With no further questions remaining, we shall move to the next session. This will be the scientific session 6, Hospital Ecosystems. I'll be chairing this session together with Dr. Khalid Tero. Our first speaker is Dr. Fatma Al-Ataibi, who will be speaking about towards logical reasoning and learning in the open dynamic environment. Dr. Fatma Al-Ataibi briefly holds a PhD in computer science and artificial intelligence from Virginia Tech and a master's in computer science from Bowling Green State University, both in USA. Her research interests include reasoning and in AI, open world machine learning, graphic machine learning, and multi-agent system. She works extensively on how symbolic reasoning and graphic-based methods can enhance reasoning in open and dynamic environment. At Virginia Tech, she served as a graduate research assistant at the Vlog Lab and as a GTA for advanced course in AI, such as graph machine learning and machine learning. She published multiple works and made ongoing contributions in these research areas. Dr. Fatma, please, the floor is yours. تفضلي.
Hello, everyone. Assalamu alaikum. First of all, I would like to ask you if you can hear me well and see my screen.
Yes, we do in both.
Yeah. So thank you so much for this introduction. Today I am very I am very honored to have this opportunity and share my research with all of you, the respected professors and researcher. And as you introduced me, I came from pure computer science and AI background. However, I would like to take my research toward a little bit of like application in the medical and healthcare, and I hope we can capture some of the challenge of the AI system in the medicine and healthcare field. So my research title, as you can see here, is toward logical reasoning and learning in the open and dynamic environment. So let's get started and first like explain what does the reasoning and learning in the open and dynamic environment. So as we all notice, we all live in open and dynamic world. We see this in every day from schedule change to a traffic delay. But these unexpected scenarios goes beyond our daily routine to impact more critical domain like autonomous driving, scientific discovery, and importantly today, medical diagnosis. So this openness and dynamism introduce major challenge for AI systems. Some of them are first, data distribution shift. This challenge appear when the trained model or the AI system encounter data that is different from what is trained for. So just to simplify it, we have a model, and this model is trained on, let's say, a specific data set. And when we test this model, sometimes the testing data set encounter new data that has not been seen before for the model. The second challenge is task complexity. This challenge appear in multi-hop reasoning question, when we have sometimes a question that contains a long chain and it needs a multiple step to derive the final answer. And when the model cannot make a mistake in, let's say, a segment of this question, the error can propagate, which is a major challenge for the reasoning systems. The third one, which I don't think we have time to cover today, is the evolving knowledge. And one major or one critical domain is like the medical field. It's open and dynamic, and knowledge in the medical field is evolving continuously over time and keep changing. So let's take a closer look at the medical diagnosis as a critical domain in the open and dynamic environment. In this domain, models suffer from the data distribution shift because the model can encounter new data during the inference. What does that mean? Sometimes the model can encounter symptoms that are not seen in the training phase. Second, the reasoning in the medical diagnosis is complex since disease, drugs, and genes are all interconnected. So we may need, I would say, mostly we need the model to be able to answer multi-hop and long chain task. The other challenge is knowledge in medicine keeps evolving. New disease like COVID-19 appears, and guidelines are frequently updated. So as critical domains increasingly requires reasoning-enabled AI, system must not only execute tasks, but also perform sound inference in the open and dynamic environment. So let's take this example. We train a model on some initial facts, and the question arises, can the model use these or those facts and rules and reason far enough to derive that aspirin may cause some certain side effect, even though this specific fact is not seen during the training and requires also a long chain of reasoning? This settings is highly significant and introduce major challenge to a logical reasoning system. As Jan LeCun noted, today's LLMs still have very limited understanding of logic, lack persistent memory, and cannot plan or reason in true sense. So for more clarification, let's take this example. We have a biomedical knowledge graph, which evolves over time and connect drugs, genes, and side effects and disease. Now imagine we have a trained model on this graph, and the model encounter a new side effect S that has not seen during the training. The key question, can the model reason that this drug may cause this novel side effect? The scenario highlights a core challenge, which we call it in computer science, is a distributional shift, and lead us to our first research question. How can we improve the learning and reasoning capability of models under distribution shift? Here we work with a knowledge graph that contains entities and relationships. To navigate through knowledge graph, we use what we call logical reasoning that allows us to derive conclusion. And to perform the logical reasoning, we need what we call logical query, and the logical query is basically the center of reasoning process. Logical query is basically question that is written in a symbolic logic. So we have natural language question, like wherever, like here, I would like apologize that this question is not basically a medical question, but it's not domain specific. So this question, it says, what genre of movies did Martin Lawrence appears? And this this question is written in natural language, can be translated to a symbolic logic, which is basically, let's say, a logical form of this natural natural language question. So as we mentioned earlier, the OOD, or the out of distribution, is a major challenge in KG. However, the OOD can appear in two ways, not only one way. First, OOD queries where the question or the query structure is not seen during the training. So it has some logical operator, for example, intersection plus projection, and this logical query and this structure is not seen during the training. And also another form of OOD is OOD graph, when the testing graph have some unseen entities. The testing graph has some new nodes that wasn't there in the training graph. So previous studies, basically as far as we studied and did our literature review, focus either on OOD queries or OOD knowledge graph, which doesn't reflect the real world, doesn't reflect the real application, because we cannot guarantee that the model only sees or exposed to OOD query or OOD knowledge graph. The real world can encounter both level of OOD. So our goal is to handle bi-level OOD logical reasoning. And to solve this, let's say, bi-level of OOD logical reasoning, we propose a generic framework that combines two modules. The first module, M1, is uncertainty representation module that deals with the KG data level OOD by modeling entity uncertainty. We used beta embedding to represent entities and queries. Why? Because beta distribution embedding capture the uncertainty and it remains bounded by 0 and 1, which support also logical operation like projection and intersection and negation too. The second module is adversarial learning, M2, that handle the other level of out of distribution for query level. So our goal here is to improve the generalization of the model to unseen query structure. And to achieve this, we introduce adversarial training around the edge between the two nodes, and which means to simplify it, we add some perturbation, we add some nodes to this embedding, and we train the model to resist this noise. We train the model to resist this change, so it can capture uncertainty or new or a new representation of the queries. So we evaluated our proposed framework on two main settings: single OOD, where we have only OOD query, and two level of OOD using two data set and different query structure. And here is some results. It may contains a lot of numbers, and but just to go overall, these are the results for in distribution and out of distribution. And it's worth noting that both data sets are not domain specific. It's true that these data sets are not let's say it's not a medical or not from a medicine field, but the framework is very generalized and can also operate in any other domain. And we're going to go to the other challenge, which is the complexity or task complexity in the open and dynamic environment. So using the same biomedical graph, which is complex and rich in relational path, the question arises: can the model trace all this long chain and infer that the drug C, as you can see here in the beginning of the chain, caused this side effect S? This illustrates the difficulty of complex inference, where reasoning requires multi-steps, and it brings us to our second research question: how can we improve the learning and reasoning capabilities of model for complex tasks? And here is an example for more clarification of how does the complex task sometimes look like. So we assume like we have some context like this and we have a question. Assume we have this complex reasoning question and we give it to a human to solve. I imagine if you read it, many of us would struggle to understand it like from the first time, because as you can see here, there are many rules and many constraints and many rules to chain, and the wording also ambiguous. And this is reflect what is like what happens in the medicine, because in the medicine the question or task has a lot of constraint, a lot of dependency. So if a human struggle, LLMs are likely to be more even confused. And this is exactly what we observed when we evaluate this kind of complex reasoning with the common reasoning methods like chain of thought, so which is a popular reasoning approach for LLM, and tree of thought, another method that comes after to solve some weakness in chain of thought, and graph of thought also. So all of these reasoning approach have failed to solve and give the true answer or ground truth answer to these kind of complex tasks. So our solution is basically based on two combined solution. The first one, we wanted to translate the text to a symbolic format, so we can remove the ambiguity in the natural language. And make it more based on fact and rules, so the model can understand the fact and follow the rules to verify the actual answer. And also the second solution, we wanted also to integrate the symbolic logic, which is, as you can see here on the left, this is what we call it, a symbolic logic with the graph. So we can represent the fact as nodes and also connect these nodes by the rules. So each node is connected by the second node by the given rules. So we can represent a long and complex dependency. So this is overall of our proposed framework. It's called Graph of Logic, and it's basically composed of three core components, C1, C2, and C3. And I'm not going to go through the technical details because it's going to be very overwhelming for you. So I'm going to go like briefly. What is the C1 and C2 and C3? C1 is called a new fact inference, and which is the component where we apply the rules for the known facts. So we have a known fact, apply these rules to it, and add a result as a new node. It uses the rule order and specificity to prioritize which facts to infer next. And then after we infer this new fact, we have what we call a hallucination verifier. We verify each inferred node and make sure it's logically sound based on these given rules. And the third component is hypothesis validator, which is the final one. And to answer the query, we filter these validated facts. We have, at the end of let's say the framework, we will have a multiple validated fact that is let's say resulted from these rules. And we want to also keep the fact that is only appear in the hypothesis. And based on that, we can tell if the final hypothesis is correct or wrong. So this is also let's say a diagram or shows how does the graph of logic work. So we have an input. This input is a symbolic logic, like a question that is translated in a symbolic logic. We have, first of all, we have a natural language that is like translated to a symbolic logic, which contain rules, fact, and hypothesis. So we have.
If you can wrap up, because your time is almost up.
Okay. So as we mentioned before, we have three components. So we infer the fact here. These are the initial fact that's given, and then we have the infer fact, and then we have a hallucination verifier, which is if the hallucination verifier sees some incorrect node, it discards these nodes, and then we have the hypothesis validator, which validate and take only the let's say the fact that is reflect the hypothesis, and then we get the final answer. So we conducted this framework on 3 reasoning type on 6 data set, and we successfully outperform the baseline for, as you can see here, chain of thought, tree of thought, and graph of thought. Graph of logic outperform all these baseline on this mostly 6 data set and 3 reasoning type. So key takeaways: medical diagnosis operates in open and dynamic and high risk environment. And so medical AI systems should be designed to operate under uncertainty and distribution shift by default, since in real deployment, we often do not know the coverage of the training data. This makes a robust and reasoning-aware model essential rather than optional for safe medical diagnosis. And thank you all, and that's for my presentation. I hope you enjoy it and also understand some of the technical details there.
Thank you very much, Dr. Fatima. And now we're going to move to the next session, which is going to be held by Professor Anis Qubba. Professor Anis is a full professor of computer science and software engineering at Al Faisal University and founding member of MUST University. He is a distinguished leader in artificial intelligence, robotics, and computer science. He served as the director of the Research and Initiative Center and Innovative Center at PSU, and has held pivotal roles such as aide to the President of Research Governance, significantly enhancing the university's global research impact. With over 2 decades of groundbreaking contributions, Professor Qubba has advanced fields including generative AI, robotics, drones, and Internet of Things, with impactful implications in smart cities, healthcare, education, and business transformation. He's renowned for developing the Arabic large language models series and leading innovative AI projects in surveillance, computer vision, and automation. A senior fellow of the Higher Education Academy UK and the series and leading and editor of over 20 Springer publications. Professor Qubba's exceptional work has earned him global recognition through numerous awards and accolades. Recognized among the career-based top 2% scientists by Stanford University, Professor Qubba continues to lead transformative research and development initiatives. His expertise in AI-driven business transformation, smart logistics, and cloud robotics positions him as a pioneer at the forefront of global AI and technological innovations. Professor Anis, floor is yours. You may start.
Okay, thank you for the introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Hayyakum Allah jami'an. So I'm just trying to hide this video panel. Are you able to see my screen?
Yes, it's clear. Yes.
Okay. Bismillah ar-Rahman ar-Rahim. Salatu wassalamu ala nabiyyina Muhammad wa ala alihi wa sahbihi ajma'in. Thank you for the introduction and for the invitation. I'm glad and delighted to provide you today talk about a very trending topic in artificial intelligence, which is agentic AI. And of course, since this symposium is about healthcare, so we're going to focus more on the use of agentic AI on the context of healthcare. So the talk is about agentic AI in healthcare, the next frontier for medical reasoning. Last year, I've talked about similar topic, but talking about more generative AI, large language models. But now the trend is going to be more forward agentic AI, where we are able to solve more complex workflows, including in medical and healthcare settings. So why actually AI usually matters in healthcare, as you already know, there is pretty much rising demand, especially in context of aging populations. الأمراض أصبحت يعني متكررة. هناك بعض الأحيان a little bit of يعني hassle for people to access medical care, خاصة في المناطق النائية. We need actually to enhance the healthcare services, availability, accessibility to everyone. Also, we have another issue, which is related to data explosion. The amount of data that is produced in the healthcare sector in particular is tremendous. If we look at the EHR systems or the images that are generated from X-rays, MRIs, different modalities, the genomic overwhelming systems, all of these require actually advanced processing. Of course, some people would say, okay, we have already some tools to do that, but these tools are basically from the old era of AI, which is very specific to particular tasks. For example, if we can do image classification on MRI images or image segmentation, that's something very narrow. But now with agentic AI, we can do actually advanced reasoning. There is also the decision complexities in different clinical settings, the burnout crisis, especially in emergency situations by clinicians or doctors. And we want to provide the best quality of service into the minimum of time. And this is where actually agentic AI can help tremendously in providing these. And automation, that's actually the ultimate objective. There is a need for automation in the healthcare sector. So according to a recent survey, they have identified, actually, researchers identified 7 domains of agentic AI in healthcare, starting from diagnosis and imaging. And I'm going to show you some of our ongoing work in this respect to analyze the scans for writing clinical notes or flagging abnormalities, drafting reports. Another sector is about also decision-making or decision support. We want to help doctors to take proper decisions. So sometimes even for a particular X-ray interpretation or disease interpretation that could be conflicts among doctors. And now we're able actually to have an AI assistance, not only to make simple classification, but also to provide justification, advanced reasoning about particular complex cases. In the context of treatment and care, so agentic AI can actually help to provide personalized plans for patients. They are able to simulate risks, generate care pathways, and this is something that we're currently doing with Taawuni MC. My colleague, Dr. Abdurrahman, is with us today. We have a collaboration with Taawuni Insurance on how we can provide best programs based on patient conditions. Also, we have in terms of engagement and monitoring, so it can help making conversation triage. And this is one of the works that we're doing with one of the companies in the UK, because, for example, during the fall season, there are many calls that are made to nurses, and basically is about flu symptoms or these classical symptoms of influenza and so on. So they want actually to use AI agent to make clinical triage whether these patients need actually to take an appointment with the doctor or they just need to start with paracetamol or simple things like this. So we can leverage the agentic AI reasoning in order to take some kind of decisions. Of course, we're not going to make prescriptions. All of this is possible, but there must be always a human oversight in the context of healthcare. In context of operation and administration, so we try to automate documentation, and that's something we're also working with Taawuni to do that. Medical coding, yes, this is something also we do in one of our startups that helps hospital to provide correct medical insurance requests with correct medical coding and to reduce insurance rejection. Drug discovery, that's another very active area where agentic AI reasoning help actually try to find the appropriate drugs according to medical regulations. And robot-assisted surgery, that's also another identified agentic AI in healthcare. So let me just get you started from the early days of AI, because I don't know if all of you already knows about, I understand that everybody knows about agentic AI, but how did we get there? So let's start from the very beginning. And I think in the previous presentation, our colleagues were talking about rule-based and semantic graph. And, rule-based, basically, this is what was agentic was AI in the beginning. So early systems, they were based on fixed rules. And in the medical context, this is what we know as expert systems. Expert systems, usually they will try to find you some kind of rules that are determined by experts. And if you have this following diagnosis, so you should have the following treatment. It's basically kind of rigid rules. So that can work in a small context, but it's not scalable. This is why anything related to formal logic, fixed rules, didn't go through too much into the AI ecosystem because of the complexity of the data and the diversity of the data. It's very difficult to model everything as rigid rules. So the second evolution that comes after fixed rules is the probabilistic learning, from stochastic models to machine learning, to deep learning, to large language model, where we are actually right now. So we come to the era of the probabilistic learning allows to understand complex reasoning, make more better representation of the real world situations, even if things are completely uncertain. So that mimics actually how we do make reasoning. احنا غالبا نعتمد على غلبة الظن في المجالات المحتملة. Not everything is certain in our human life. We need to take decision with kind of uncertainty. So uncertainty modeling is actually what makes AI now shining and resulting in what we know as large language model and agentic AI. So to have this evolution clearer, this is how it goes. In the early 50s, we had people have worked with rule-based systems, and they developed expert systems with rigid logic trees. And then back to the 80s, machine learning has evolved, and where features were extracted manually to try to identify patterns and make predictive modeling. That was working pretty much fine in the early days of the internet for spam classification. And then, neural network, although it was kind of an old technology from the 60s, but it didn't shine a lot because it requires a lot of computation power. But there had been a lot of work in the 80s, on the 90s on deep learning, but it didn't go through until 2010 with the emergence of GPU machines with much more computing and memory allocation in computing devices. And from there, things have completely converged to neural networks until back in 2018, we had the technology of transformers, which had generated large language models, which we knew back in 2022 as ChatGPT. And now we are in the era of agentic AI, which is basically based on large language models, but added to this, its connection to external systems. So this is just to make you more illustration about the drawback of rule-based expert systems in healthcare. This is how healthcare systems have started. We just try to go to experts, doctors, and say, okay, if you have certain symptoms, give us what will be the diagnosis. So it has been something like, if you have symptom, patient and fever, and patient has cough, and the patient has shortness of breath, then the diagnosis is patient and pneumonia. This is how expert systems were built in the past. That has inherent limitations because it's very rigid. It failed to handle ambiguity or adapt without manual updates. It has poor scalability. We cannot model the world with just certain rules. That's not possible. The world is much more complex than if it can be represented by complex and rigid rules. And it requires high maintenance. Everything that there is a new knowledge, we need to integrate this into the expert system. So it's true, it's clear that it cannot be generalized. And this is why the community have moved as to probabilistic reasoning and probabilistic modeling. And this has led to the rise of large language models, which has been used in clinical documentation, medical chatbots, knowledge retrieval, and coding assistance. So let me give you some intuition about the applications that could work. This is an application that we have developed. It's basically an interactive chatbot. So we can talk with the chatbot either in English, either in Arabic. It's like you are talking to a doctor. And at the end, what service the agentic AI will provide us is a medical assessment report. This medical assessment report is just a compilation or a summary of the whole discussion, where we can see what are the symptoms. In some other interfaces, we have also extracted the ICD-10 coding and CPT for treatments and so on. So that becomes very similar to a human. You know, I even talked to him with natural language in my Tunisian dialect, and it was able to understand what I have and provide me like a correct diagnosis report. So another application also that helps doctors is the note auto-completion. So for example, in hospitals, doctors take a long time to write notes. So now we can actually make suggested recommendations to the doctor. And using agentic AI, we will take into account all the patient history. We will take into account the current state of the patient, and we will help to make an auto-completion to the doctor so that it can save a lot of time in writing reports. We are able also to take into account the doctor writing style. Okay, so we try to generate something similar to what he used to generate in the past, as you can see. So just making a tab completion, we can have this auto-completion provided, and the doctor can just, check. You can see we can provide ICD-10 codings, we can provide CPT for medication, and so on. So, however, the LLMs have come with shortcomings when we use them just alone. LLMs are just text generator. They only excel at text generator. They lack capabilities on reasoning. They work just single-step reasoning. They cannot have a complex overflow. They have no persistent goals. They forget, they have a weak memory. They cannot remember past conversations. They don't have real autonomy, and they don't have native access to the tools. And from that comes the idea of agentic AI, and people start to plan a single agent where an agent is connected to external resources like tools, like databases, connected to memory. And the agent, basically, it's an AI system that can plan actions. So when I ask any question to the agent, it's not going just to generate text. First of all, it's going to think about the question, understand the user intention. It will make a planning, then it will execute decisions using its tools. It will observe and monitor the result that it has generated. If there is any kind of mistake, it can actually make several iterations and adapt, okay, based on the feedback that is received by the end user. This is how agentic AI systems work. So how did we move from LLM to agents? Basically, the integration of LLMs with several external tools. We can add memories. We add also planning activities. It's when you have a complex task, you cannot solve it. Even we as a human, when we have very complex tasks, we need to make a plan. How should I execute this task in advance? And for this, I need to have external tools. I need to have a memory. I need to have an understanding of the whole context. And the execution loop is going to iterate several times to make a plan and then to execute the plan until the overall task is achieved. So basically, the component of agentic AI ecosystem, we have in the middle, or the core component, is the LLM reasoning core. So we will use the LLM as a reasoning engine. And we will connect this LLM to external tools. For example, I can connect it to an external API, the HIS of the hospital information system, to bring the customer information, or external services. I can also make a memory. So if you make now a discussion with the agentic AI chatbot, if you come after 1 week, it will remember the previous discussion and can build over it. So we're going to have kind of a persistent memory. So you have a planning engine. When you ask a question, it's going to start by making a plan to help solving complex problems. You have a feedback. So this is like a human in the loop. You can say, okay, I want to have more information. I want to make sure that, for example, the diagnosis is correct, depending on the task that you want to do. And you have also action executor. So you can even execute codes. You can execute sending SMS, sending emails. So it can be pretty much connected to any external resource in the context of a medical healthcare ecosystem. And why do we need a healthcare why healthcare needs agentic AI? Because the healthcare ecosystem is very complex. It works in real time. We need to have continuous monitoring of the patient surveillance. We need to have real-time alerts. And this is beyond of human capacity. This is why in hospitals, usually we have 2 shifts, 3 shifts per day among the doctors, because it's difficult for one human or to maintain all of this. And still, the task is tremendous. We have multi-step processes. We have complex clinical decision pathways. It cannot be solved by neuro AI or a simple large language model prompt engineering. We need to have system coordination. So these agentic AI need to be integrated into the HIS, into the CRM of the hospital to understand the whole context for any particular task. And also, more importantly, it must be safety aware. It must make risk assessments. So using agentic AI, we can have feedback control to check whether any decision is actually aligned with the safety aspects. And personalization, because individual patient context matters in decision making. So this is also another personalized chatbot that we have developed. You can talk to an AI agent, or this is we did it between a human and 2 humans that talk together, and we log all their conversation. And at the end, the doctor, at the end of the conversation, he will be able to check the diagnosis with ICD-10 codings, the primary complaints, the vital signs, everything that was discussed. It will be summarized using clinical notes. And this is done through agentic AI solution.
Professor, just to remind you that we still have 3 more minutes.
Okay, yes, I'm almost done. And this what actually gave the concept, the concept of agentic chatbots who are able to track patient progress over time, schedule follow-ups, and monitor medication compliance. Another very popular topic in healthcare is the visual language model in action, where we can use agentic visual language models to make diagnosis of X-rays, of MRIs, or any kind of medical imaging. So here, this is a simple application where you can upload an X-ray and you can have a very detailed report. And currently, we are working at Al-Faisal on something more advanced where we use a 3-layer agentic AI system in the context of dermatology. And this is like an existing work, very in late 2025. It's called Skin, where they have used fine-tuned a visual language model to make a diagnosis of skin cancers. Afanallah wa iyyakum. So we have actually improved over this work to propose a 3-agent multimodal system. And we are able to, when you upload an image, the LLM is not going to give you a diagnosis. It's going to search a database of similar cases and to bring us what are the most similar cases. And based on this, the LLM can have a context to generate more safely the diagnosis based on previous clinical context. Another work that we work in neuroscience is the chatbot for well-being analysis, خاصة لمرضى التوحد أو الأمراض النفسية. We can use this to extract patient information. خاصة العديد من المرضى لا يريدون التكلم مع الطبيب النفسيين. Using agentic AI, when the patient is more comfortable to talk about his situation, and based on this, we will analyze according to the standard. So last thing that I present is the surgery pilot, where we use agentic AI to support surgeons to take decisions, to document their work, and maintain safety while doing surgery aspects. Okay, I need to stop here because of the time shortage, and I do have some other videos that I can share later on, maybe by presentation. This is like the platform that we've developed to help hospitals writing correct claims to insurance companies. And this is using also agentic AI in 3 steps. We rewrite the medical note and we review the medical note according to the insurance policy requirement. And finally, we draft the insurance claim for the insurance company. And this is being integrated now in Oman in one of the hospitals with a very successful feedback from them. Okay, thank you very much. And if there are any questions, I'll be happy to respond.
Thank you, Dr. Anis. Unfortunately, we are running late on time, so we will have to introduce our next speaker, Engineer Lama Al-Awlaqi, who will continue on the same line of topic. She will present agentic AI tools in health practices. Engineer Lama is an AI researcher at the AI Center for Advanced Studies Dhaka in King Saud University. تفضلي دكتورة لما.
Assalamu alaikum. Thank you for the introduction. Just a quick check. Can you see the slides and hear me clearly?
If you can start the show and if you can speak a little bit loudly.
Okay, can you hear me now?
Yes, we can hear you, but can you start the show?
Okay.
Yes, thank you.
Again, thank you very much for the kind introduction. I'm really pleased to be here today and to have the opportunity to share the session with you. Healthcare is one of the most complex environments for artificial intelligence, not because the technology is immature, but because the context is sensitive. In healthcare, decisions are made under time pressure, data is fragmented, and the cost of error is not theoretical, it is real. So when we talk about AI in this domain, the question is never just, can AI do this? The real question is, how do we design AI systems that actually help clinicians and researchers without introducing new risks? Today, I'll talk about agentic AI, not a futuristic promise, but as a practical design approach for using AI responsibly in healthcare. To keep this discussion focused and practical, let me briefly explain how this session is structured. So this session is designed to gradually build understanding. First, I'll explain why AI agents are becoming relevant in healthcare now, and why this moment is different from earlier AI adoption rates. Then I'll clarify what agentic AI actually means, because the term is often used loosely to describe many very different systems. After that, I'll walk through a set of key ideas that consistently appear in real healthcare AI experiences. The shift from actionable insights to actioning insights, where AI agents should not be used, how to assess organizational readiness, common agentic patterns that work well in healthcare, and why many AI pilots fail after initial success. Finally, I'll bring everything together using a realistic scenario with Manus AI to show what responsible agentic AI looks like in practice. So let's start with the core problem agentic AI is trying to address. One of the biggest challenges in healthcare today is information overload. Clinicians are not short on data, they are overwhelmed by it. A single patient encounter can involve years of historical notes, lab values across multiple systems, and imaging reports, alerts, reminders, and documentation requirements. Traditional AI helps by adding predictions, scores, and alerts, but in many cases, this actually increased cognitive burden. Instead of reducing workload, AI sometimes added another screen to check, another alert to interpret, and another task to manage. This is a key insight from recent healthcare AI discussions. The bottleneck is no longer prediction, it is coordination and prioritization. So AI agents matter because they operate across steps, not just a single moment. So what makes AI system agentic rather than just automated? Agentic AI is often misunderstood as full autonomy. In healthcare, agentic AI should not be autonomous. Instead, an AI agent is a system that has a defined goal, can reason over multiple steps, can use tools such as databases, EHRs, or literature resources, and can take steps, can use tools also, and can take bounded actions under human supervision. The word bounded here is critical. An AI agent doesn't act freely, it operates within constraints defined by clinicians, researchers, and governance teams. This is very different from a chatbot that answers once and disappears, or rigid automation that cannot adapt. Agentic AI sits in between adaptive and control. The difference changes how we think about AI outputs. For many years, AI in healthcare focused on actionable insights. The system tells you something is high risk, abnormal, or worth attention, but insight alone doesn't change outcomes. Clinicians still need to search for context, review supporting information, and decide what to do next. Agentic AI shifts the focus to actioning insights. The agent prepares the decision environment, it gathers relevant information, organizes it, and places it into existing workflows at the right time. The human remains responsible for judgment and accountability. This distinction is essential for safety and trust. However, reducing friction without boundaries can be dangerous. This slide is essentially uncomfortable. Most AI talks focus on where AI can be used. This slide focuses on where it should not be used. Today, AI agents should not make final clinical diagnoses, treatment selections, high-risk trial decisions, or ethical and legal judgments. Many healthcare AI failures didn't happen because the technology was weak. They happened because AI was placed in the wrong decision space. AI agents are excellent at preparation and organization, but when decisions involve patient harm or legal responsibility, the final authority must remain human. In healthcare, restraint is not a limitation, it is a design principle. Once boundaries are clear, the next question becomes readiness. So many organizations ask, what AI agents should we build? A better question is, are we actually ready to deploy one responsibly? Readiness means having a clearly defined workflow pain point, clean and accessible data, a named human owner, and an acceptable cost of error and a governance process. Without these, agents fail, and the failure is often blamed on AI instead of poor design. Successful agentic systems start with clarity and governance, not with technology. So when readiness exists, design patterns become critical. Agentic AI works best when it follows patterns. Healthcare workflows already follow a predictable mental model, and agents should align with them rather than disturb them. For example, in the pattern prepare and then human decides, the agent summarizes information, but the clinician decides. Also, in monitor, then alert, then escalate, the agent watches continuously, but humans intervene when thresholds are crossed. These patterns ensure humans stay in control, actions are auditable, and systems behave predictably. Patterns are what make agentic AI safe enough for healthcare. After discussing agentic patterns, a natural question is, do these systems actually exist today? The answer is yes, but in very specific bounded forms. On the clinical side, tools like NAMSDAX or Suki AI focus on documentation and workflow support. They handle coordination-heavy tasks, but leave clinical judgment entirely to physicians. On the research side, tools like Manus, Elicit, and Site.ai act as the agentic research assistants. They search, organize, and synthesize evidence, but stop short of interpretation or conclusions. Finally, many healthcare organizations build custom agentic systems using frameworks like LangChain or semantic kernels, integrating with the clinical data standards such as FHIR. What all these tools share is not autonomy, but bounded, supervised, multi-step behavior aligned with the healthcare workflows. Many healthcare organizations run AI pilots successfully. The demo works, the model performs well, but very few pilots survive in production. The failure is rarely technical. Most pilots fail because there is no clinical owner. The system is not integrated into real workflows. There is no monitoring after deployment and no exit or rollback plan. Agentic AI exposes these weaknesses very quickly. The good news is that starting responsibly doesn't require complex systems. The best first agents are simple, low risk, and useful. They save time, reduce administrative burden, and build trust. Examples include pre-visit patient summaries, documentation assistance, and prior authorization preparation. These agents don't change medical decisions, they change how work feels. So let me now bring everything together with a concrete example. In this scenario, Manus supports a healthcare researcher. The human defines the research question, inclusion and exclusion criteria, and trusted sources. Manus performs multi-step tasks, searching, filtering, extracting, and organizing evidence. At every step, the human can intervene. Manus doesn't interpret results, it doesn't draw conclusions. This is agentic AI done right by goal-driven tool using and multi-step, also human supervised. So let me show you the interface of Manus. So for those who may not be familiar with Manus, Manus is an AI agent framework designed to execute goal-driven multi-step tasks by interacting with tools, external sources, and environments. Unlike traditional AI tools that respond to a single prompt, Manus is built to plan, act, and observe over multiple steps while remaining open to human intervention at any point. What makes Manus particularly relevant to healthcare and research settings is that it doesn't aim to replace human judgment. Instead, it focuses on handling coordination-heavy work, such as searching, organizing, synthesizing, and preparing information, and then pausing when human validation or decision-making is required. So let me briefly explain the Manus interface. We are all aligned on what we are looking at. Is my screen clear to you?
Yes.
At first, thank you. At first glance, the Manus interface may look familiar. It resembles a conversational interface, but functionally it behaves very differently from a standard chat-based AI. At the top, we start by providing a goal, not a detailed instruction list. In Manus, we are not telling the system how to do every step. We are defining what we want to achieve. This is important because agents are designed to interpret goals, plan steps, and decide which tools to use. This is the first key difference between an agent and a chatbot. So when I entered the prompt, I asked him to make your task here is to support a researcher who is exploring the topic. The goal here to help the researcher understand existing academic landscape around this topic. And I gave him the topic. So as Manus starts working, you'll notice that it doesn't jump directly to a final answer. Instead, it shows intermediate steps, such as searching for sources, selecting tools, processing information, organizing outputs. This visible step-by-step behavior is critical in healthcare and research settings. It allows humans to follow the agent's logic, intervene if needed. If I want to intervene here, I can do so, and understand why a certain output was produced. This transparency is what makes the system governable. Another important part of Manus interface is how it uses tools. Manus doesn't rely only on its internal knowledge. It actively interacts with search engines, databases, documents, external resources. You can see when the agent decides to search, choose a source, or process, retrieve information. This reinforces the idea that the agent is not guessing, it is working with evidence. One of the most important design features is that the interface allows human interruption. At any point, the human can pause the agent, refine the goal, correct assumptions, or stop execution entirely. This aligns perfectly with healthcare requirements. The system is not running autonomously in the background. It is collaborating with a human in real time. Finally, Manus typically produces structured outputs rather than a single response. We'll go now to the end of the comment. For example, it organizes summaries, group findings, clear sections, highlighted uncertainties. This is especially useful in research and clinical preparation, where structure matters more than fluency. So I think it reaches the end of the process. You can see here the output, how it was done. So to conclude, agentic AI is not about replacing clinicians or researchers. It is about reducing cognitive load, restoring focus, and enabling better human decisions. The safest AI systems are not the most autonomous. They are the most respectful of human judgment. So I know the time was limited, but I hope this session helped clarify how agentic AI can be applied in healthcare in a practical and a responsible way. Thank you, and I look forward to your questions.
Thank you so much, Doctor. And now we're going to move to the next session. Dr. Yusra Al-Madhami holds a PhD in Computer and Information Science with a minor in Mathematics from Purdue University and a PhD in Computer Science and Engineering from the University of Connecticut, USA, where she specialized in artificial intelligence with a focus on developing data-driven methods to address real-world challenges in healthcare and beyond. She's an active assistant professor teaching and supervising students in machine learning, deep learning, computer vision, and data mining. Her research and applied work span a wide range of impactful projects, including employing graph neural networks to improve diagnostic safety, reducing patients' readmissions through probabilistic methods, developing AI-powered iOS applications for dentistry, integrated hospital platforms, and building assistive technologies for visually impaired individuals. She has also contributed to emergency response system, such as using ensemble methods to geolocate disaster-related tweets. Dr. Yusra, floor is yours.
شكرا دكتور خالد. Thank you very much. السلام عليكم ورحمة الله وسعد الله صباحكم بكل خير. Good morning everybody. My name is Yusra Al-Madhami, and today inshallah I will be presenting an informative presentation. Let's say it's an informative presentation as opposed to persuasive presentation. And it's an interesting topic embedded with a little bit of conflicting point of views between physicians and AI experts. And the topic of this presentation is leveraging the graphical neural network to enhance diagnostic safety and reduce physician burnout. So it's more like, hey, can we fix something to avoid a physician burnout? This is just basically a domino effect. I designed these slides to a medical professional audience. I'm not sure how many medical professional audience with us today, but the meaning that I try to make it less technical in terms of computation and computer science terms and so on. So let's take a look at our roadmap. I'll try to place these in within 20 minutes. Presentation. I will go over my personal opinion about AI experts versus the physicians, the relationship. And then we'll go over the problem, what most of these AI experts see in the field of healthcare. Is it based, and we're going to ask the question to physicians, is it a blessing or a potential headache in the future, additional workload on you? And then we're going to take a look at our system architecture, but I'm going to show you the system architecture, and then I'm gonna take this architecture component and explain each part individually in a broader way, and then in the end we're gonna see if it basically a challenge or the challenges of the AI, and it's just a one statement, and it basically wraps up this whole presentation. Okay, so I would like to provide my personal opinion about how AI experts feel about solving problems for physicians. Basically, I would call them a helicopter moms, these AI experts, where basically they take a look at a scenario in a hospital and they would say, hey, I think the physician would actually take advantage of this. I want to fix that problem for the physician. Okay, which it should be the other way around. Clinicians actually should lead the AI instead of basically following it. Okay, so it should be the other way around. So the technicians, the clinicians or the physicists should basically teach the tech experts what they actually need in their healthcare environment. So both of them, both of them should be educated. The physician should be educated how the AI system works and what does it do? And then also the AI expert should listen to physicians and ask them the question, what do you guys need so we can help you in the future, okay? And why do most AI experts basically come up with solutions for physicists that they didn't ask for? It's because they get sick. And when they face different challenges, they would say, hey, I think I can solve that problem with AI. Okay, this is a scenario right here, which is the biggest question, some of the biggest questions AI expert or any basically person who visits ER rooms, emergency rooms, is why does it take so long after the treatment in ER? They told us you're being discharged. We're just wait here a second. Okay, we'll be right back. Why does it take a long time? Well, basically there are several things going on behind the scenes that they were told it's because of that. It takes a long time. Is, for example, physicians waiting for the lab work, imaging results, diagnostic tests. That's why it takes a little while. And when they receive those, they need to reevaluate what they thought that the patient could have. And the worst of all, which is the pajama time, which is basically the writing these discharge summaries, prescriptions, detailed aftercare, the medical plan basically for the patient. Also, that in the ER environment, usually patients arrive according to the severity, so they have to shuffle things around, and they provide priority over writing a discharge note for a patient who's waiting there for almost an hour on the side. And of course, some of them, especially in the ER rooms, they have short staffing, and that could be leading to a problem, okay? So AI experts say, Okay, I can help them with the lab work. I can just basically get the lab work and use an AI model that basically tells the patient directly, hey, you have that disease, and you have, this is the result, and what are the basically, it explains these lab work, or explains the imaging results. So the imaging results we can see in Saudi Arabia, basically we can actually see our imaging results before we even meet the doctors, as opposed to the United States. When I do an imaging, the imaging, I don't know what they call it, the image, the people responsible in these rooms will refrain from telling the patient. They would say, you have to meet your doctor. They can tell you the results of those. Nowadays, actually here, especially, they actually provide you with what the expert is saying in these images and so on. So these are the things that an AI expert would look like, and would basically try to figure out a solution for it, okay? And this quote, I said that quote to one of my close friends. He's a doctor, okay? And I told him, hey, I think I am only a human was invented by a physician, this code, because with this too much work, discharge summaries, too much patience, less sleep, so much anxiety, so much work, not to mention what is waiting for this person back home and so on, eventually there will be some kind of a human error. And this error, unfortunately for physicians, could be catastrophic. And it could not only reflect on the patient, but it could also reflect on the resources, the hospital resources, the possibility of also having the physician basically doubting themselves. This is really based on what I surveyed most of the physicians about how do they feel when they make when they have a misdiagnose the patient. They would say, I was overwhelmed, I cannot think straight. So the million-dollar question is, we want to mention that as AI experts, myself, we want to say that AI basically complement physicians' tasks rather than replacing them. Okay, so there are several examples right now in the field that uses AI to help the physicians and the staff or medical professionals. Some of these very interesting examples is flagging abnormalities in imaging before radiologist even opens the file. Okay, so just to flag it, place a square around these abnormality, and even place a diagnosis underneath this box. But eventually the radiologist or the physician would approve it. Basically, they will have to go over it again, but at least it pointed out the location for the physician. So it expedited a little bit of the process. Another example of AI being used in the healthcare is drafting patient-friendly explanation of a lab and test results, okay? So when a doctor comes into the patient room with the lab results, they would say, hey, you have an elevated white blood cell count. That actually means you have an infection inside you, so we're gonna give you antibiotics. Well, AI can do that. It basically looks at the levels, it studied millions and millions and millions of lab results and the diagnosis, and just infer from that and provide a very good simulation. Basically, a document will be sent to the patient with this information, as opposed to the doctor writing it down or even explaining it for patients. AI listens to a patient-doctor conversation. Instead of the doctor go after they make a discussion, they would go back and write it down, write what the patient have. How about you have a transcriber, basically? This one is really good because most of the EHR, the electronic health record, contains a lot of grammar mistakes. It's unstructured, it's not organized. When you have an AI that does that for you, it will be very clean and organized. There's also ChatGPT developed by Google. It's called MedPal, and it is a designator for residents. It was trained on millions and millions of Q&A from the medical field. And these residents can use that ChatGPT to just reinforce their decision. Epic sepsis prediction model. This is a very interesting model developed, and it's been integrated in most hospitals in the United States. And what it does, it basically predict a possible predict if the patient will develop sepsis, and basically it monitors this patient every 20 minutes and checks the vital signs and everything around it, and make a prediction. Hey, there's a possibility in the future, in the next hour, this person will develop sepsis. So this is a very good integration of AI. Tempus AI model focuses on precision medicine. Basically, what it does is that it helps the oncologist. The AI model helps oncologists customize the chemotherapy for individual cancer patients. So this is really amazing in terms of hopefully later in the future we could have medication specifically designed for individual patients. Now, from all of that, how about we add, this is just 6 examples. There's many situations where AI can basically replace routine procedures or tasks that the physician would have to go do every day. I want to add additional one, which is our model concept, the model that we would like to build. We're actually in the process. We actually built it. We just in the steps of the graphical neural network. We'll get to this in a moment. So we basically looked at the whole patient diagnosis thing, and it's been there, done that. Okay, but there are several ways we can connect patient with diagnosis with diseases. There's many ways we can forecast, especially, for example, readmission, the possibility of readmission using a lot of AI models. Our architecture is a hybrid. It contains 2 main components, okay? You have to focus on these. One is a transformer, and one is the graphical neural network. Each of these models, okay, these, by the way, these are AI models, okay? Both of them are trained, needs to be trained, okay? Now, let's take a look at what a transformer is. We're gonna get into which transformer we use, okay? These are basically, we call them the linguist. They take the doctor discharge note and they convert it into a high dimensional data embedding or a vector, okay? That contain a numerical values, a numerical vector. Instead of a text, it converted into a numerical vector, okay? And then we have the graphical neural network, which maps these embeddings, okay, into a complex web of relationship. You can see where we're going with this, okay? We're clearly gonna take all the patient discharge notes and have them as nodes in a graphical neural net in a graph. And these edges is basically if the patient had this disease or not, or could actually, is this link or edge could be missing, and the idea and the graphical neural network would predict that missing edge because there's a similarity with another patient. So these are the 2 main components, and what we can do with these, we can do 3 things. We can predict the possibility of patient being readmitted, okay? I've done this previously with ensemble methods. It's considered as the GPS traffic alert. So you want to predict if me discharging this patient right now, there's a possibility that this patient will be readmitted immediately. So if you actually can predict this, at least you'll be able to reduce the resources of having this patient readmitted by tackling it. So notice that it's a flag for the physician. We can also predict a diagnosis. So we call it the Facebook of medicine. You have 2 nodes that represent 2 patient discharge nodes, okay? And you want to predict one of those patient discharge disease. You will look at the other patient. The 2 patient discharge summaries look very similar. But one of them was diagnosed with a hypertension, but the other one is not. This will provide a flag or alert to the physician and say, hey, this discharge summary you just created with this specific diagnosis, you're missing a hypertension. There's another person who has the same discharge summary. This physician, by the way, not necessarily will diagnose with hypertension, but will be able to contact the physician who diagnosed the other patient and say, why did you diagnose this person with hypertension? This is just an example, by the way. And of course, we can do an intelligent triage, okay? We call the smart priority inbox. And the concept here is we try to determine, predict which is severe, which is not. And this is a fast, you can do all of these three depending on how you program the graphical neural network. So let's keep two things in mind, just for the physicists here we have in the audience. We are not basically guessing blindly. We are using all of the physician's own notes, which is the ground truth, and the augmented insight, which is basically it provides a second opinion. Whatever we're going to develop, it provides as a second opinion because it looks at a vast amount of data. And then we train the model on this vast amount of data. Remember, physicians spent, I don't know, maybe 12 years of studying before they become a surgeon. But imagine you have a machine that's been trained on all of the medical health aspects. So you have a very intelligent genius that is being your sidekick on the side. So let's take a look at the architecture, the system our system architecture, or the skeleton in the scenario. Look at these numbers, 1, 2, 3, 4. These are the pipeline process. So 1 is the data preprocessing. 2, we're going to apply embedding. We're going to convert the text into embeddings, which is into a numerical format. And then we're going to take these embedding and feed it into the graphical neural network. And the graphical neural network will basically make a prediction whether for a diagnosis, we're going to predict readmission, or we're going to predict the severity of the disease. And we're going to take a look at one by one individual. We're going to start with the data processing. So let me let you know about the data set. We collected it from PhysioNet, from a hospital in Boston, the data physionet.org. By the way, we had to take training, HIPAA certifications and all of that. So we had to go through a series of workshops in order to get these data. So it is confidential. You need to go through this process in order to capture them. The data set we have three types of data sets. We need those. Discharge summaries. So these are doctor notes for over 100,000 patients, okay? And then we have the ICD codes. Okay, these ICD codes, ICD stands for International Classification of Diseases, okay? And basically every disease, they assign a code for it. It's easier, especially for insurance companies, they need to have the ICD codes, okay? And these ICD codes assign to each of these summaries. So if I have a hypertension, there's an ICD code attached to that hypertension, okay? But we also got, have the ICD codes standardized description. So if I see an ICD code that says 900, what is it? If I go to the ICD code descriptions, I will see the explanation of this ICD code. So here's a sample. I can't provide you with a lot of these samples for privacy purposes, but you can see the top one is a sample discharge summary for a patient. You can see it's unstructured. There's a lot of mistakes in there. There's a lot of empty fields, double spaces, and so on, okay? On the left side, you will see the ICD codes for each of the discharge summaries. So you can see, for example, on the left, this is just one patient subject ID that was given several ICD code, which is understandable because when you go to the hospital, they give you several diagnoses. You have hypertension, you have a fever, you have and so on and so forth. And each of those have an ICD code attached to it. Next to that, in the third data set, which is the descriptions. So if you look at the ICD code on the left side and you map it to the description, you can see, for example, ICD code 90, ICD version 9, and it stands for infectious colitis, enteritis, and gastronitis. So I can't pronounce the last one. So why do I need to show you this? Because what we used as a text for the transformer and the graphical neural network, we're going to take the summary for the patient, this text right here, and the description of its disease for that specific summary discharge. So in the pre-processing, it is very important to note that we didn't actually do a lot of cleaning to the discharge summary. It is very dangerous actually to do that, because transformers are very intelligent linguist models that understand context from these texts. So it is very dangerous, and we want to make sure that we are not removing stop words, numbers or lab results, anything that has a dash. So we only removed the obvious ones like empty parentheses or double spacing, okay? After this data cleaning was done, we applied tokenization on the text. And tokenization is the process of taking this complex medical narrative and cutting it into the smallest meaning units, okay? We call it tokens, okay? So an example here, the patient has an acute appendicitis. It will be broken down into these terms. Notice the word appendicitis. It broke append as the root, and citis means, which is a suffix, means inflammation, okay? And how did it do that? Well, our tokenizer was trained on millions and millions of medical notes, so it is familiar with medical concepts. So hyper is elevated, tension, it will break it into two words. The next part, after we did a tokenization, we pass these tokens into the transformer. Now, by the way, GPT stands for generative, pre-trained transformer. The T in ChatGPT is a transformer, okay? So Modern BERT is the latest one. It's a transformer that was trained on millions of medical text, discharge summaries, and so on. So what is it? It converts tokens into numerical vectors. We call them embeddings, okay? Why does it do that? Not only that, first of all, the computer doesn't understand text. It needs to see numbers. That's the first thing. But also when it converts these text into numbers, it embeds contextual meaning within it. So the vector we end up from these embeddings has a meaning. So an example we have here in the, we have two medical concepts that are considered similar: shortness of breath, pulmonary embolism. They are projected into the embedding space with the similar numerical values. So their vectors will be very similar. And if you imagine them, there are two vectors in space, they are close to each other. Okay, the closest, the angle between them are close. That every time, the closer, the smaller the angle between those two vectors, the more similar they are. And here's an example of what do we mean by that? We have a text input, we tokenize it. So we have the cat chased the mouse. Tokenized text will break it into parts. You have token IDs. By the way, Modern BERT doesn't do token IDs, so it will immediately jump and assign each of these words an embedding. Notice on the right side, we have...
Doctor, please, may I ask you to wrap up, please? Time is running.
Okay. So we actually apply the tokenization and embedding on both discharge summaries and on the descriptions, which is basically the diagnosis for that discharge summaries, okay? Then we apply contrastive learning, which is basically what it does. We train the Modern BERT to learn that these ICD descriptions are close to these notes, and these ICD descriptions are not related to these notes. So the final one, which is the graphical neural network, now we have a smart embeddings, okay? What we're gonna do, we're gonna feed these embeddings into a graphical neural network. And graphical neural network is an AI tool that doesn't look at individual entities, it looks at the relationships between them. So now that we have the diagnosis, descriptions, embeddings, and the patient's notes, you can imagine that now we can actually map the relationship between patients and their diagnosis. And we can actually do all of these three predictions. These are three different types of graph, by the way, graphical neural networks, and each of them does a specific task. But if we're gonna relate them to our three predictions, we're going to see that if we're going to do possibility of admission, we're going to train our graphical neural network to do graph classification. If we want to predict a missing link between a patient and diagnosis, we're going to do a link prediction. And if we're going to do predict if it's urgent or a routine, we're going to modify the graphical neural network to do node classification. So I try to wrap it up as much as possible, but remember that the AI still will mess up at some time, but that's why we call a human in the loop. It eventually remains the most critical component of the system that a human should verify the answers of the flag that is given by the system. So I apologize for the delay, everyone. If you have any questions, please ask me these when we join the break rooms, inshallah. Thank you very much, and I apologize, Doctor, for the delay.
شكرا دكتورة يسرى. We have to move to the next.
Which is going to be given by Dr. Mohammed Jamil. Mohammed Ghayat Jamil. Dr. Mohammed is a distinguished consultant in pulmonary critical care and sleep medicine, serving at King Faisal Hospital and Research Center in Riyadh, Saudi Arabia. He holds several leadership roles, including director of the Tele-ICU program and acting section, head of the critical care department. Dr. Jamil is also president of the Saudi Sleep Medicine Society and holds academic appointments as a clinical assistant professor of internal medicine at the University of North Dakota and adjunct assistant professor at Al Faisal University. Throughout his career, Dr. Jamil has pioneered innovative healthcare initiatives, most notably founding the first Tele-ICU program in the Middle East. He has previously served as chairperson and director of the Home Mechanical Ventilation Program at King Faisal Hospital and Research Center. Dr. Jamil is an active member of the numerous professional societies, including the American College of Chest Physicians, the Society of Critical Care Medicine, the American Academy of Sleep Medicine, and the Saudi Society of Critical Care. His principal interests include e-health and the advancement of telemedicine, renowned for his dedication to patient care, education, and innovation. Dr. Jamil continues to make significant contributions to the fields of pulmonary critical care and sleep medicine. Dr. Jamil, you may start. Floor is yours.
Assalamu alaikum. I don't know if my screen is clear to you.
Yes, it is. But just to let you know that we can see your notes.
Okay. So let me just do some adjustment. I'll give you a second.
Yep, it's good now. Yep, you may start.
Okay. The way this is better. Right. Assalamu alaikum. It's really an honor and privilege to be in this meeting. I learn a lot from my other colleagues with previous presentation. Again, I'm a physician. I'm not an IT guy. I don't have this expertise, but I'm interested in all the AI tools, how it's going to help my patient. So I started working more to find out how I'm going to translate all this work into my bedside that's improved the patient. So I'm gonna try to show what's work's been done already over the years and in this field and how it's reflecting on our patient in the ICU. So I was starting this study back in 2023, an artificial intelligence in critical illness and its impact on patient care, a comprehensive review. So as you see, as a physician, I can recognize the disease, but I need other tools to help me. So the AI can try to predict some progression of the disease, can help me in the aid in complex decision-making and to recognize a unique pattern. A lot of now the study and the work is to identify the same disease if it have a different pattern, which physician without a help from the AI might not able to recognize it. But we're having a lot of challenge so far with AI, including the data privacy, interpretability, and decreased clinical readiness. And it's still need a lot of standardization. So we need guidance for future, how we're going to improve this work by efficient data transfer, data de-identification, rapid processing, quality control, and decentralized federated learning. So this is a study just published in 2025, and it's a part of an umbrella review for the value of the machine and deep learning in management of critical care patient. So just probably most of you know this, machine learning, deep learning are closely related to the field of AI, within the AI. The machine learning focus on developing algorithm and model that enable computer to learn from data, whereas deep learning as a specialized branch of machine learning employs multiple layers of neural network to extract high-level abstraction from raw input that the physician and the lab will give. Each layer in the deep neural network build upon the future learned by the previous layer, allowing for a progressively more complex data representation. It took me a while to review it, so if we understand this, will help us to understand how this machine learning, deep learning work. Many study, if you look here in the table one, and to look into the AI, and those are studies, if you can see, they use different articles and they look into the result and what's the goal of the study. And there's a lot of limitation. Now, when we look into the AI and it started in the COVID, they try to look into how we're going to improve the care in the ICU by learning if there is any subtype of the patient. We look into prediction of worsening of the patient. Early prediction for an intensivist is really a key work for my practice in the ICU. There is a lot of problem, and basically is how to give the data for the AI to really transfer this information properly to the patient, and we'll discuss it more. So in those studies they look into the AI can diminish the load of dealing with large-scale information and give me also information about patient who can develop MI or can worsen from the ARDS, and I will discuss it further in different articles. This is also the amount of study, and they look into sepsis prediction and also on ventilator prediction. More further study, but if you look here on the right side, there's a lot of those studies. When they get reviewed, they have a lot of heterogeneity. Also, there is a lot of bias in the data that's give us about our patient. They study a big group of patients, cancer, GI, cardiovascular disease, sepsis. So now a lot of those study in the AI look into different disease. So, but there's always an ethical concern. For me as a physician at the bedside, my priority is my patient. بغض النظر what kind of patient that the technique or the AI giving me, but I need to protect my patient. For there is the to patient privacy, and this is really a major issue for most of the hospital. How we're gonna keep the patient privacy from leaking? There is a deficit in informed consent yet. So we need to inform the patient, and our patients still, they might not understand why we're utilizing this data. There is an erosion of trust due to opaque model behavior or undisclosed conflict of interest. Also utilizing this data for personal interest. And we need a regulatory and legal uncertainty further complicate deployment with unclear delineation of liability and accountability for AI-informed decision. So here in this review, and you can look into, there is a lot of limitation for a lot of program. So if you look into, there is different program that utilize for the AI now, but all under study, and a lot of them is not deployed yet into practice. There is a lot of potential bias. There is need still there is need improvement in methodology and validation, and to avoid this bias, so we don't give wrong information to patient. Now, the outcome that they're looking is basically to predict mortality, also to predict length of stay in the ICU and the complication of the ICU. Same thing, more study on the same topic. So in conclusion for the study, they said machine learning and deep learning model offer promising opportunity for treating patients in the ICU, but their clinical application remain limited due to insufficiency external validation methodology, inconsistency, and unresolved ethical issue. To narrow the gap between research and practice, future work should focus on developing clinical interpretal model, standardization of assessment protocol, and addressing ethical implication through proactive governance framework. So this is also transforming like some of the work, and this is back in just in 2025. This is how to utilize AI for sepsis management. And unfortunately, they use a different model, and basically, since the positive predictive value is still very low, and the deployment is still limited, and you can see as mentioned in different lecture about the EPIC, which is having is number one now utilizing electronic medical record in USA. And the limitation is basically still related to the data and accuracy. It's the more you give data for the AI, the more give you accuracy. And currently, I don't think we reach this level. But the work is now starting to get more data, and I'll look into here. We're trying to get more genomic, epigenomic, transcriptomic, and proteomic, and metabolomic. Those are information still for us as a physician, clinician, are new, but this is what we need, because in this way, when the AI processes the data, can give us a little bit of subcategory and subphenotype for the patient. So not all the patient can be treated the same. It's giving me some risk stratification, and this is giving me the mortality. It's for resource and also focus on the proper treatment for our patient. So the data input is very important. As a physician, I'm the one who's gonna feed the data yet. There's some electronically can go through the vital sign, and some that a physician, as the previous lecture they mentioned, that I need to feed this data into the system, and the system can analyze it. And again, will help the system to give me the best prediction. So this is another also article, and this published in 2024, talking about artificial intelligence to advance acute and intensive care medicine. And the key point was artificial intelligence application in acute and intensive care medicine have the potential to streamline workflow, and this is what we need as an intensivist, and to enhance assessment, prediction, and medical decision making. Widespread of artificial intelligence integration in acute and intensive care is impeded by ethical, legal, technical, organizational, and validation challenge. Future advancement in artificial intelligence have the potential to transform the landscape of patient care for acute and intensive care medicine. So they categorize for me as a physician, I need from AI an early warning system to give me a prognostic tool, model that suggests treatment, disease phenotype, and also resource management. So another article back, this is in 2021, when they start moving from buy to bedside, and this is another systemic review. And in 2021, systemic in this review showed that most artificial intelligence study in the ICU are carried out to predict complication up to 22%, followed by prediction mortality 20%, and improving the prognostic model 18%, and the classifying the subpopulation. Those numbers, if I can achieve it, it's helped my patient, it's helped the resource, and also it's helped to really, now we're talking about money, also how to mobilize the patient and treat them properly. Sorry. So if you look into the study that's based on this, currently most of the study is focusing on model prototyping. We have really not reached the level of study that's look into clinical outcome evaluation, very minimal. So now I think we're still looking into validation of this model, and we're not reaching to utilize it at the bedside yet. So, and you can see most of the study is non-randomized. And as you know, as a physician, the best study for me is a randomized clinical trial, which give me a more accuracy in predicting the disease and also the outcome. Same thing here to characterize the outcome of clinical, and most of the studies still not giving me, except like a lot of them, no information. Give me about pressure ulcer, sometimes sepsis related, the hospital mortality still, and the p-value is very good. So tell me that we are in the process, and I think we're heading in the right direction this time. Another study, and this is also in 2025, this is for ARDS, acute respiratory distress syndrome, this is a major issue for us as an intensivist. When I sit in ICU, all the patients are the same? So in this model, they try to feed the AI all the information from intervention and how to manage it. And at the AI can give me really a different category of recommendation, either by adjusting PEEP, which is how the patient, if there's no physician here, is to utilize a special setting on a ventilator, maybe utilizing different medication, or basically help me to predict who's going to get worse and utilize really ECMO, which there's a circulatory outside the ventilator and the patient. So the way the AI will give them data on many patients, and at the end, the AI can predict from new patient based on what's learned from previous experience from different patients. So we needed this to create this model by properly feed the system the proper physiology, the proper ventilator, the proper lab, so the system can predict and give me a good recommendation. And there is here, this is this in those multiple study, this is application of AI in early prediction diagnosis of ARDS. And basically, they use this different model like the VWD, the different model of AI. And some of them now start giving the physician, the bedside, some rapid diagnostic support, improve ARDS, and identification early on for those patients. This is also prognostic, also give me some prognosis, how the patient is going to improve or not. Also can give me a different clinical by adjusting the PEEP, adjusting recommendation, different medication, maybe paralysis, and to wean the ventilation. All this tool, the AI can help by feeding the right data. Also, as I mentioned here, in those two studies, it's giving them also the proper ventilator setting, which help the physician to adjust the ventilator for the best for the patient. This is also to predict asynchrony when the machine, the ventilator, and vital sign will feed it to the proper system. It tells them that the patient is not synchronized event, which this is very bad things in the ICU. And in this way, the physician can have an early warning even by giving more medication to paralyze him, change some of the setting, and that will help the actually have a very big impact on our patient. This is also to adjust the ventilator or maybe put the patient in a prone position. Those studies also show that's good improvement by utilizing those AI model. Also utilizing an ECMO. I'm going a little bit fast for the sake of time. This is also I need to focus. That's this study also was back in 2007, and this is AI, and it's randomized on patient survival and hospital lengths of stay. And this is showed the severe sepsis prediction algorithm was assessed in a single center, and the average hospital lengths of stay was 13 versus 10.3 in the AI model. And the mortality also was different based on this model, which helped the physician to identify and have a plan for their patient. And this is comparing the hospital control versus the experimental and lengths of stay. You can see when they use the experimental, they were able to identify the patient earlier. And again, it will there is amount of reduction in hospital length stay by 2.3 days, length of stay by 2 days, and in the hospital mortality by 12.3%. Same thing, can see the hospital mortality comparing the control was experimental. But we have to remember this is only one center study, and we cannot draw a big conclusion from it. And there's another study in 21 uniting intensivists on data scientists, and they use this as the Amsterdam UMC program, and there is a relative risk reduction around 14% could be achieved, which might have a significant impact on patient and society. So those show that really using AI have a good impact on ICU. So here the information, what kind of data that we need to really feed it to our system. It's really big data. And I'm gonna just go faster, I think, for the sake of time. I need to remind the people also who practice that most of the study really need, before you adopt it, that we need an external validation. And this was studied after the first study was in 2021. They did repeated from a different center, and they did an external validation to show that it's important, which was positive in this study.
1 minute, Dr. Riyad.
Okay, so I'm just gonna go quickly here. When we decide to start an AI project in any hospital, like in my hospital, we need to put a framework, and we have to call for action to get really a human and team to be prepared for that reason, and to find what we need from information to be implemented and where our goal in this system. But we have to remember, based on the study in 2023, to look into the team. We need nursing, physician, we need biotech, and we need pharmacy, social medicine, all to be involved. And they have really already in this study showed what kind of basic study that we need. We need to have a basic knowledge of AI. We need the social and ethical implication. We need also an AI enhanced clinical encounter. So I'm not going to go through each one. We need to put evidence-based evaluation of AI-based tool, workflow analysis of AI-based tool, and practice-based learning and improvement regarding those are the education needed for your team before they start doing an AI experiment in the ICU. So I will skip this, but just to put into perspective that's any AI project, we need to look into bias, avoid some ethical for data privacy. Those are major issue before we can apply it to our patient. I will skip this and I'm ready for any question. I don't know, maybe later. Thank you so much.
Thank you, Prof. Riyad. Fortunately, we don't have time. Maybe in the breakout rooms, if I may have the chance to invite you to join the previous speakers who are available in the breakout rooms. Thank you for all our speakers. Thank you for your attendance. Please join us in the afternoon in the 7th session, and please join the breakout rooms in the link you see in front of your screen. With this, we conclude our 6th session, and we look forward to meet you in the 7th session, inshallah, in the afternoon. Assalamu alaikum wa rahmatullahi wa barakatuh.